from the American Academy of Pediatrics.
Welcome to this bonus episode of Pediatrics on Call, the podcast on children's health from the AAP. I'm Dr. David Hill.
And I'm Dr. Joanna Parga-Belinkie. This podcast is for everyone in the medical community, keeping our children healthy and safe.
It's a show by pediatricians for pediatricians.
But anyone who cares about kids will get a lot out of it as well. Let's jump right into this special episode on the 2026 vaccine recommendations, published by the AAP and endorsed by 12 other medical societies.
Joanna, I'm a little exhausted by having to constantly defend the incredible power of vaccines.
I know vaccines and their safety and efficacy have been a hot topic. David, we can't stop talking about how important they are for children's health. They not only prevent acute infectious diseases, but they also prevent chronic diseases.
I guess when you get to help families protect the health of their children, you take every shot you can to give them the best medical advice. Okay, I'm feeling invigorated, but also like we have to talk about what's happened to our vaccine schedules in 2026.
Good thing is, David, the vaccine schedules at the AAP haven't changed. Our guidance is consistent and clear. It's the Centers for Disease Control and Prevention's recommendations that we need to question. And we're going to need the help of vaccine expert to do that, Dr. Pia Pannaraj.
Dr. Pannaraj is a member of the AAP Committee on Infectious Diseases and a professor of pediatrics at the University of California, San Diego. Pia, welcome to the show.
Thank you very much for having me.
Pia, how long has the AAP been issuing vaccine recommendations for kids?
The AAP has been issuing the recommendations since the 1930s, since the start of the AAP, actually, even before the CDC began having their committee to review recommendations.
And since the CDC started issuing their own recommendations, have the recommendations of the American Academy of Pediatrics always aligned with those of the CDC?
Well, not always. In the beginning, there were some differences. So the AAP had their own set of recommendations until about the 1990s. During that time, it was decided that, it's much easier for parents and providers to follow one set of recommendations. And so they were more aligned. Even so, there were always just a couple of minor differences that AAP might recommend specifically for children that weren't in the main schedule from the CDC.
It's starting to feel like maybe the differences aren't that minor. What were the changes the CDC made to the routine vaccine recommendations for children, and can you list them?
So over the past year, there have been several changes that were made to the CDC recommendations. And some of that didn't follow the routine way that the CDC used to look at the evidence for making those changes. And so in August of this past year of 2025, the AAP began releasing its own set of recommendations again that now are starting to deviate from the CDC. Or what I should say is the CDC actually began to deviate from the routine schedule that both organizations had.
Now, one of the major changes was the removal of certain recommendations for vaccines. Can you tell us what vaccines were removed from the schedule?
Sure. Yeah. The CDC just last week removed 6 vaccines from the routine schedule, and they changed them to either recommended only for high risk or recommended with shared decision making. And the vaccines that were removed included hepatitis A, hepatitis B, influenza, RSV, the rotavirus vaccine, as well as meningococcal ACWY, and the HPV vaccine was also changed.
Pia, tell us more about these different buckets of categorizing the vaccines. You mentioned 3 different ways in which the CDC is thinking about vaccines. Can you go through each different way and tell us if some of these vaccines can still be given?
Yeah. So first, I think it's important to point out that according to the AAP recommendations, all of these vaccines should still be given. And many states actually have either new laws in place or alliances with other states to ensure that they're still able to follow the evidence-based recommendations, which are the AAP recommendations. So some of the changes that HHS proposed or are now recommending are changing certain vaccines to be required only for high-risk groups. So examples of those are hepatitis A, hepatitis B, and RSV. So first, let's just look at RSV. The RSV change, it seems like a change because they're saying it's recommended only for high-risk groups. But the high risk is defined by babies whose mother did not receive the vaccine, which is actually the same definition for the AAP recommendations. So nothing has actually changed. It's just, unfortunately, making things a lot more confusing for both the parent and the provider. And then hepatitis A and B, so those are now being recommended with shared decision-making and for high-risk individuals. The problem is no one ever thinks they're high risk. It's just one of those things. We've tried using hepatitis B for only high-risk individuals, meaning for a newborn, it's if mom tested positive for hepatitis B surface antigen during pregnancy. The problem is some pregnant persons don't get to prenatal care, and some have prenatal care in one place, but then deliver their baby at another location. And so the records aren't shared. And so it's really easy to miss the results of that screening test if that screening test even took place. That's one of the reasons why we have the hepatitis B birth dose. It's because we know that that helps to prevent the hepatitis B from transmitting in those cases where there could be potential missed screening results, or if there's hepatitis B in the rest of the family for who we didn't screen. So all of those recommendations that were there before are there following a really thorough review of both the safety and the effectiveness of these vaccines.
And in that answer, you mentioned shared decision making. I mean, that sounds like a great idea. I think we've always been doing it, but what does that mean in this context?
You're exactly right. It's something that we as pediatricians, as doctors, always do. We always discuss with our patients. If families have questions, we are there to answer them as pediatricians. And the vaccines are always their decision. If a family comes in and they're not sure, they'll ask the questions. We give the answer and the final decision is up to them. So nothing has changed in that respect. The hard part, though, is the way the new HHS reframes shared decision-making. The way it's framed now, it seems like we're not sure about these vaccines, that maybe they should be recommended for some, but not others. So it puts a question mark on these vaccines, even though nothing has changed in terms of the evidence that we have or the data that we have on, how safe these vaccines are or how effective they are at preventing the disease at the specific time that they're given. There's going to be more discussions from patients to the doctors. So it's true that pediatricians are going to have to be prepared for that they're going to have to anticipate the questions and know the answers. But in terms of the recommendations, nothing has changed.
So, Dr. Pannaraj, as a pediatric hospitalist, I'm noticing that we're having a horrendous flu season this year. Is there any barrier to parents getting their children protected against flu or COVID if they want?
Yeah, so as you know, flu is still a recommended vaccine on the AAP schedule, even though HHS changed that to only being recommended with shared decision-making. And even though we're in the middle of the flu season, we still encourage anybody who's not vaccinated to go get the vaccine. You can get it at your pediatrician's offices. Depending on your state, the vaccine could be available from the pharmacy as well. They'll usually vaccinate down to about 3 years of age. Below that, some pharmacists are not comfortable or haven't been trained on how to vaccinate toddlers or younger children. In some states, it's becoming a little bit more difficult because the vaccine has to be only given by the provider, while in other states, some of those laws and alliances has allowed pharmacies to continue giving the vaccine. So it's important to know what are the capabilities and availabilities within your own state.
And I know pediatricians always love to talk with families and make sure that they're aligned in the care they're giving. But how are you worried the proposed changes by the CDC will actually harm children?
I'm worried that it gives parents this signal of ambivalence, that we as doctors could go either way on these vaccine recommendations, when that's not really the case. We know that these vaccines help to protect against these diseases. We know it keeps the children out of the hospitals and in schools, learning like they're supposed to be doing. So now with the shared decision-making, it's giving this message of ambivalence, as I mentioned earlier. And the other issue is that it means that the parents and the families have to advocate for themselves. The pressure, the onus now is on the family to come to the doctor to say, hey, should I get this vaccine? And as you can imagine, that's also going to create a lot of disparities because some families have access to information and they know to ask, or they feel comfortable asking the doctor, while other families might not. And they might not see the doctor as regularly. And so if all of a sudden the vaccines are not routinely discussed or routinely given in the office, then those families might not get the vaccine for their child. So that's where it becomes a little bit of a bottleneck or a concern. The other concern is that could be happening right now, but probably some of these ideas that maybe these vaccines are not as important, that's going to last for many months to years to come. And that's something that we're going to have to work on, over the next several years.
It seems that these recommendations mirror those of, say, Denmark. Now, how is America a different place from this small European country?
Yeah, that's a great question. So HHS reviewed the recommendation schedules for many countries, and they chose Denmark, which has one of the fewest number of vaccines. Denmark's a small country, 6 million people. I just moved from Los Angeles. 6 million is significantly less than the county of Los Angeles. That's just one city in the whole United States. So we are a much bigger country. We are heterogeneous, unlike Denmark, which is very homogeneous in its population. Denmark has an excellent healthcare system where every individual is seen within basically one system. So healthcare records are accessible for every single hospital, every single clinic, no matter where you are in the country. And as you know, that's just not the case in the United States. Our record system, health information systems don't communicate with each other. So we might not know who received what kind of care at their last visit. The other thing is they have a universal healthcare system. So every individual is covered by their healthcare system for all of the care that they receive. So they can go to the doctor whenever there's any concern. We here in the United States, unfortunately, don't have that either. So our care is broken up. Some people receive excellent care. All routine visits are there, while others, and unfortunately, it might even be more people than not who don't get that routine care because of lapses in insurance coverage or lapse in any kind of coverage. And so our vaccine recommendations were built based on what is known in the United States. It's based on the epidemiology of disease in the United States, based on all the safety and effectiveness data from the United States. And so we can't base our schedule on another country because it just doesn't make sense.
And Pia, how does Denmark compare with peer countries in terms of the vaccines that they recommend?
Yeah, Denmark actually has one of the fewest number of vaccines that they recommend compared to their peer countries. And it likely is because it's such a small country with a homogeneous population compared to other countries in Europe, for example. Now, there are other vaccines that are given in countries that we here in the US don't give. So some examples of that are BCG vaccine for tuberculosis or the malaria vaccine. So again, it really is that each country has to look at their own population and what's needed for the people that live in their country.
And knowing that, what processes should we be using here in America to choose an appropriate pace and timing of our vaccines for our children?
Yeah, that's a great question. So when we decide the timing of vaccines and the pace of vaccines, so first let me take pace, because pace has a lot to do with how long it takes our immune system to make the antibody response to the vaccines. And then we determine when that needs the second dose to boost. That's sort of the easy way to put it. Timing is really dependent on when we see the disease in children. So there are some diseases that affect kids during their infancy. An easy example of that is rotavirus. So rotavirus causes diarrhea, and that leads to significant dehydration. That leads kids to have to come into the hospital, receive IV fluids. Even though rotavirus can affect kids of all ages, it's during that first 2 years of life that the child can become significantly dehydrated and need to come in the hospital. And that's the reason why rotavirus vaccine is started, at 2 months of age. The same is true for the other vaccines that are given during that 2, 4, 6 month time period. We want to give the vaccines before the kids are at risk for disease, and also at the time where we know they'll make a good response to the vaccine.
Will insurance companies continue to cover these vaccines?
So right now, the HHS has stated that all insurance companies will continue to cover the vaccines that are available as per the original schedule. And all of the vaccines can still be given and be covered by VFC for the 52% of children in America that are on VFC. So that's reassuring. But there are some concerns of, if or when that could change. I mentioned earlier that some states have formed alliances, and part of that may be that they have either laws or recommendations in place for insurance companies to continue coverage within their state. So that's another safety rail.
Well, Pia, I'm hoping you have some last takeaways for listeners who might be feeling a little tired or frustrated about these non-evidence-based changes that are affecting our lives and our patients' lives.
Thank you for that question. It is frustrating to have these constantly changing recommendations that aren't based on clear evidence, with transparency for everybody to review and to understand. But the good thing is that the AAP, really, we haven't changed our recommendations. So for providers, they should be doing the exact same thing that they've always been doing. So following those same recommendations that they're used to, it should be business as usual for the providers. I think what's going to be potentially frustrating is that there's going to be more time required to answer questions and discuss the vaccines. But that's what we as pediatricians are trained to do. We're trained to talk with the families and try to understand what their concerns are and answer those questions. So, we're in the right place to do that. And the American Academy of Pediatrics is trying to make sure also that all of the information for frequently asked questions and other resources are available for pediatricians.
Dr. Pia Pannaraj, thank you so much for joining us today.
Thank you for having me.
For more information on vaccines and the AAP recommended schedule, visit our website at aap.org/podcast.
Well, that's it for today's episode. If you like Pediatrics on Call, please subscribe on your favorite podcast app and help us spread the word. Follow us on YouTube, Facebook, and Instagram at Pediatrics on Call.
Pediatrics on Call is a production of the American Academy of Pediatrics. Our producers and editors are Ann Jansos and Claire Keating. Our audio engineer is Doug Nagel. Joe Puskars is our associate producer, and Susan Martin is our executive producer. Our theme music was composed by Matthew Simonson. Join us next week when we'll bring you the February edition of First Up.
We'll speak to the Associate Editor of Blogs, Dr. Rachel Moon. I'm Dr. David Hill.
And I'm Dr. Joanna Parga-Belinkie. Thanks for listening.